Our next patient is a 62-year-old male presenting to us with NSTMI with a fair LV function. The angiography shows 80% calcified stenosis in the LAD diffuse, and OM shows around 80% stenosis. RCA shows a diffuse long segment disease with calcification around 90%. RCA is arising from the left coronary cusp. Our plan is to do a LAD LCX and RCA plasty, IVUS guided.
The moderators for this session are Dr. Mamas, Dr. Tejan Patel, Dr. Khaliquzzaman, Dr. Lachuman Das, Dr. Rajesh Vijay Vargi, and Dr. Sharad Jain.
Hey, hi. Hello.
Hi, we're looking forward to the case.
Great. Okay.
Video.
So this is Kwan and Sanjay Shah is doing the case. I'm here assisting him. He's doing a puncture now, a distal puncture.
I have already given local anesthesia.
He asked me to do the puncture. I said, wait a minute, let him do it.
Okay, I got it.
So it looks very easy for him to do it.
So I'm just making it parallel to skin so that whenever it enters radial artery, it.
I think Sanjay has the best counterpunching technique.
I agree with that.
So I learned counterpunching technique from him also.
I think me too, I can say that.
Thanks.
I think the trick for setup to the distal puncture is the hand set up vertically to the patient. Is it true, right?
Yes,
this is
yes.
the one very facilitated.
And anywhere where we get the base pulsation, that is a site we puncture.
Right.
Not
So,
a particular point.
so let me get a EBU 35 and we started LAD and the circ first. Then we can design. You guys see the angiogram, right? Any comments from the panel?
Can you show us the diagnostic first?
Oh, okay, just 1 second. Do you have diagnostic show to them?
So we're still not able to see the diagnostic.
Okay, good. Pressure okay?
Yeah.
Okay, good. Give a test.
No, you've taken a JL, please.
This is
For
EBU.
EBU.
Okay.
EBU 3.5.
Can I have the run-through eye? So this case, they want us to do an IVUS guidance.
Which view you want to show?
Yep.
Which view?
Wait, cranial view is fine. AP cranial.
Okay.
Can I have
Take
the?
view?
Oh, okay.
Okay, fine.
This one, right?
Okay.
Well, from this view, I can see the left means some lumpy, bumpy thing, and the mid LAD, an 80% tight lesion with some calcification around that.
Which wire?
I need a run through. You run through?
Run through.
Yes.
Yes, run through. You want second view?
Yeah,
For
sure.
circumflex?
Yeah, for circumflex.
AP quarter?
So, Doc, what you thinking about? Is that balloon approach or?
I'm thinking about
debulking?
IVUS. IVUS first, and we can decide. Okay, good. So the caudal will show a long circumflex lesion is also about 80%. So I'm going to wire the LED first and IVUS it, and we can discuss. How about that? Agree or not agree?
That's a great strategy. I think the IVUS will be very
Yes, sir.
important. It will tell
Leader of
you
the ship.
the degree of calcification. It will tell you whether it's napkin calcification and you need modification therapy such as rotablation. So I think IVUS in this sort of situations a must.
We are IVUS catheter ready?
Why not
I was
OCT?
catheter,
Because
yes.
it's not a left
I
main.
was wanted.
I'm sorry, can I hear?
Why not
was-
OCT?
Why not OCT?
I was तैयार करो.
I think we see a lot of OCT today.
So post
There's enough
procedure-
OCT.
Post stenting will do, na? I was
Oh, you want post-standing IVUS? Okay.
because it's a long case.
Oh, okay.
Yes, Tak, this is Surya. So actually the recent meta-analysis also has shown that the OCT guided has a similar outcome compared to the IVUS guided. So actually we can use IVUS as well.
Epicranial, epicranial.
Can you? So we're talking OCT guidance PCI versus IVUS guidance PCI. I think we had an expert here, Dr. Yawasak. Can you answer a question for them? IVUS guidance and the OCT guidance.
There are two data, multi-center data, opinion trial and Illuminant 3 showing a non-inferiority of OCT guided compared with the IVUS guide. But it's planned to demonstrate the non-inferiority.
We are ready.
So we are expecting some superiority of OCT. There are some advantage and disadvantage
Let me do this one
in
first and
both
the next one I do.
modalities, as you may know.
Discussion.
Right? So, but if you focus on the specific condition, for example, the severe calcified lesion or the bifurcation lesion, I think OCT may have some advantage compared with IVUS. I think,
see.
yeah.
Yeah. The most recent study for the IVUS is the Lumino.
Ultimate study, right?
Yeah,
Yeah, from
correct.
China,
Yeah, from
right?
the-
Yeah,
From Dr. Chan's group
Yeah.
in Nanjing Hospital.
yeah.
They show a significant benefit for IVUS guidance PCI.
Yeah.
Okay.
I agree.
So I think it's a more powerful study
at the
than
moment, yes.
at this moment. So I
Yes.
think IVUS is the really almost a gold standard. That's my belief.
At the moment, yes, I agree. But OCT also tried to demonstrate the superiority compared with angio guide by Illuminant 4 and COCOA study. We are expecting the result
Yes,
within a year, right?
expecting that.
Yeah,
Okay.
right. So,
I think so. I
Yeah.
think so. Okay. I think the result will be robust
and
for
the
the
importance,
OCT.
it is okay, yes. The importance of an imaging guide is to obtain the optimal result.
Yes.
Even in ultimate study, they compare the optimal result and suboptimal result. There are significant difference in the long-term prognosis. So
Okay.
it is important
I
to
think
obtain.
the lesson, most likely, regardless OCT, IVUS, is an imaging guidance. What do you think?
Yeah, I think I agree, yes. But again, I would like to say there are several advantages and disadvantages in both modalities. So you have to choose that depend on the lesion, which should be better, right?
Correct. Yeah. What is your opinion for the panel? What do you think? You still think OCT is superior than IVUS?
I think OCT is much better than IVUS. We will see the result actually of OCT and IVUS, and pictures will speak on its own in 10 minutes.
Well, IVUS, we can do it in less contrast. How about that?
I mean, it very much depends on what you're using your modality for. So for left mains, I would say IVUS for assessment of the degree of calcium thickness, IVUS. I think for everything else, I would use OCT.
In our institution, I just do the IVUS guide for left main orifice and RCA orifice region and CTO. Other case, we do the OCT guided.
This is a long lesion, and then the assessment will be very, very fast and then very understandable with the OCT than IVUS. And of course,
Can you move the monitor a little bit?
we have to reduce the amount of dye used. Probably
Maybe a little bit
you
to,
can reduce the number of diagnostics. You can
About
combine the
on this side
diagnostics
for him to see.
along with
Okay.
the OCT
Here,
catheter.
it will come here.
You may reduce the amount of
No,
dye.
how about him? He needs to see that.
I
too.
agree.
Okay.
Yes, the most of the concern
I
is
think I
the
can
total
see it.
amount of
come
contrast.
in.
However, if you do the
Okay, you
OCT
ready?
at the same time of
we see?
angio,
Can we see live?
we can reduce
Yes.
total
Okay.
amount of
Yeah, start
contrast.
recording.
How to reduce the
Okay,
contrast
this
is
still put back the LED. Okay.
okay.
So I don't see this is pretty okay, the lumen.
Yeah,
The lumen size about 2.5.
2.5, yes.
Yeah, 2.5.
right.
So,
Right.
so we still in
still in the
the mid to distal.
yeah, yeah.
Okay, we have
It's at the
still
difference, yes.
relative normal here.
Yeah, no plaque here,
Yes.
right? Yeah. Looks
You guys see the imaging, right?
Yeah, we are seeing that.
Yeah.
Large picture.
We can see some
Yeah.
plaque coming out.
good. Yes. Not too much. It
Not
might
too
be
much.
yes. It might be some compression from the myocardium there, right? And here we have
Some calcification
calcium now, right?
Calcium about 180.
Yeah.
this
Yes.
is a
It's
lesion.
the lesion. Yeah.
Okay.
The lesion
it's
should be
here.
around 1.5 millimeter, right? Yeah. And then also the calcium from 3 to 6 degree, and then also the very fibrous, thick, eccentric calcium, right? Eccentric plaque. Yeah. And here also some calcium, right?
Mm-hmm.
Yeah.
So I think this is reassuring in that it's not completely concentric, so it should be relatively dilatable with regular balloons. not
Yes,
confined
yes, I
balloons.
agree. But the plaque,
Good.
including the calcium, is very eccentric.
So
So,
right here is pretty okay, the
Yeah.
lumen at this area, right?
yeah,
Okay.
nearly 2.5 to 3, right? Yeah, yeah,
about
3 of-
3 vessel
yeah,
here.
right. Still some eccentric plaque, fibrous
Some
plaque.
plaque,
Yes.
but I think I want to avoid that. I don't
Yeah.
want to overlap in this area.
Yeah, right.
So it's a very proximal
So
area.
here is
There's
a
left
bifurcation,
main,
right?
bifurcation,
Yes,
left main coming up,
right.
some calcification,
Some
but
calcifications.
should be okay, right?
Okay. Yes.
The luminal area should be
Yeah.
okay. Okay, great.
Region is very similar to the angio findings, right? Yeah,
Correct.
yeah.
Okay, I think we can stop.
Okay, stop.
Okay, so now we had we should these cases have some calcification, but it's not so severe.
Can we see the angio screen on the board, please?
Can you show the angio?
Yeah, we got it.
Angio reflector.
We need them.
So, Doc, what do you think about OCT
Next.
and IVUS now?
What do I think about IVUS? I don't need to do a rotor. Number one, I think we can comfortable dilate it with a balloon and then stent. The stent size, I think the 3.0, the length, probably about 32 to 28 around the area. 32, I think comfortable.
Question was, what was better? What is
Okay,
better?
which balloon?
IVUS or OCT?
Yeah,
Which
give me a
balloon?
3.0. Actually, yeah, 3.0, 3.0
NC.
balloon, NC balloon.
3 by 15
So
NC.
which one's better? You tell me. We still debating here?
No, I'm asking your opinion.
My opinion, I'm doing IVUS now. So my IVUS, I think is pretty good. I get a very good information. But I think OCT will give the same information too. But the winner, we don't know until we have some double-blind study. But at this moment, I don't think IVUS is inferior to OCT. What do you think, Dr. Mamas?
I mean, it's very situation specific, as I mentioned earlier. So for certain cases, I'd
Nine
use
AR,
IVUS.
3 by 15.
The majority, I'd
Chances
probably use
are
OCT. I think the main discussion is whether you should use imaging, and in my view, you should. For most cases.
Okay. Now, the information I got, I think is very important, so I can dilate it with balloon comfortably. And the stent, I pick out the right side and right length, and this is what I want. And after that, we do a post-IVUS to see how the stent doing, and we can finish a one lesion. So I'm using 3.0 high-pressure balloon to dilate the lesion first. Test one. Okay, go. Right. So these are 15, right?
12.
12.
3 by 12.
Okay. 3 by 12. good. You open up, good.
Yes.
Do you
One
make
more.
much use of the virtual histology information on IVUS TAC or not in your cases?
I cannot hear. So 12,
Do you
12,
make much use of virtual histology in your
24,
cases?
28, okay?
Virtual
It's
histology.
okay?
Okay.
Yeah.
28.
3028?
3028.
You agree with 3028? 3028 stand?
3028. લઈ આવો લખેલો છે લઈ આવો.
A lot of proximal calcium, was it a concern for us?
Yeah, some proximal calcium, but it's not severe by IVUS. And the luminal area is very
Right.
good.
Very
So
good, yeah.
I'm not intend to cover all the way to a proximal.
That's another issue with
28.
IVUS, because superficial calcium that hides the thickness of the calcium, which is beneath
28.
that.
3 by 28.
Yeah.
Yes.
So OCT goes over that.
Okay.
That actually gives the thickness, and then whether you'll be able to need to debulk or not with a scoring balloon or cutting balloon.
Yeah, at the moment there are three ways
This
to,
is expedition,
treat
3 by 28.
the calcium, right? One is in the rotablator, the other is in orbital atherectomy, and the new one is a shock wave. So I would like to say if the nearly circumferential calcium rotablator should be very wonderful to identify the thickness of calcium, and we can use the rotablator very safely. But the problem is an eccentric calcium, right? Nearly less than 180 degree. At that time,
What do you think?
I do not have enough data of an orbital atherectomy, but that might be the one of the option to treat. So identification of the calcium location, thickness, it might be very important to treat the severe calcified lesion. Are there any comment from the panel?
12, right?
12.
So what this one?
Before we go there,
14.
can you
14.
say
Okay, down, down. 14 down.
advantages and disadvantage of two different IVUS system?
Yes, by OCT we can measure the calcium
That's IVUS
thickness,
again.
and if
No,
the,
no, I'm asking for
I was
conventional IVUS versus volcano with the histopathology.
conventional IVUS and could you tell me again?
Volcano.
Volcano, the virtual
to see
histology.
results.
Yeah.
No, take picture.
Previously, there are some data of the virtual histology, but in the
So
field
how's
of
the angel doing,
intervention,
guys?
I think
Looks
Yeah,
like
there
angel
are
looks
no
good.
Looks very good.
significant
Yeah,
difference.
so let me IVUS it again and let's see.
Guiding needs to
Yeah,
be
okay,
adjusted.
that's fine.
So there are no data showing the virtual histology improved the prognosis compared with grayscale IVUS.
So TAC, what MLA are you aiming for now that you have deployed the stent?
Yep. I'm sorry,
What MLA are you aiming for?
for after the stand?
Yes.
Well, according to the Illumin study, the area, at least a 5, for the stand area, at least a 5, 90% of the reference diameter.
Right.
And we don't see much distal dissection. And we covered the distal plaque 50% at least. We don't want to see 50% plaque of the distal and the proximal segment. This is a definition when we do the IVUS guidance for a good result. So 5 MLA is the stand, will be the optimal one. Okay, good. Get live. Okay,
Yeah.
pull back. Yes, yeah, pull back.
Here is a little bit distal to the stent, right?
Can we have the IVUS? Yeah.
Yeah, can we see that, right? You see the IVUS?
Yeah, we
Okay.
can have the picture-in-picture angio or something like yeah.
Okay, the
That's
stand coming out.
Okay, here comes the stent, right? Yeah. Yeah, the very symmetric dilatation. Yeah, right.
2.5 stand, okay.
Yeah, here is an eccentric plug, but still the symmetricity is good, and the stent size is nearly 2.5 to 3, right?
Yep.
Yep. And also, you can identify the calcium in the 3 o'clock, but still, symmetricity is wonderful. Here some tissue prolapse, right? Yeah, in the 7 o'clock, right? Yeah, our position looks good.
Yep. It's still about 3.
Yeah.
It's a diameter. The stand, good.
Yeah,
Then
here is
that's it.
a very thick fibrous plug. So, in the
So
proximal
that's it.
side, yes.
Yeah, can I stop that? Okay. Can we see the stand area? Go to the stand, yes. Good, right here. Yes.
Yeah.
Yeah, get the area. .89 the area. I think Peter okay, right?
Yeah, I think it's excellent result.
Okay. So I don't see some dissection in a distal.
No.
And I think the area covered really well. I don't think I want to do more. Do you agree?
It's okay, good.
Okay, good. All right. So this one finished. Let's go to CIRC.
So the CIRC lesion looks at worse, moderate. Are you planning to pressure wire it?
The CIRC lesion?
Yes.
I forget the CIRC lesion, how it look like. Okay, can I call the wheel?
Yes.
Caudal.
Caudal. Epicaudal.
So let me put my guide back in first.
Okay. Select your LED.
Yeah. Give me shake a little bit.
Shape. Needle.
Can I needle?
Yes.
Can we see the CIRC shot?
The first diagnostic
Can we
shot.
repeat the entry for them? I think a long lesion.
Next, sir. Next. Okay.
I mean, I think you should pressure wire that. I wouldn't be doing a PCI without more evidence of functional significance to that lesion.
What's your guess? As we have discussed, it is going to be negative.
We don't know.
You want to show RFR?
No.
Yes.
Oh, small branch. Huh?
Small branch.
Sometimes a wire in the LED helps, sometimes to readjust the position of the guide.
Yeah.
So before pulling out the
this
LED
is
wire,
definitely-
we sometimes take the other wire to wire the circuit. So,
There's a lot of branches.
yeah.
Hello, Caudal.
This one?
Yes, this.
It's there, right?
Yes, yes. Direct.
Yeah. Just direct stand. Yeah. Let's take a picture.
Okay.
Let's see what length.
Picture.
Yeah.
Okay.
So a little bit smooth, this one. I think it's another 3024 or 28.
28.
28 is okay, right? Yeah.
32.
From normal to normal.
32.
Okay, field 32, Sanjay suggests.
32.
So after that we IVUS it.
You don't want
Because
to pressure wire it?
I think we just direct stand this one.
Yes, thanks, Surya here. So,
Yeah.
I think the lesion is, it is a moderate lesion. It's around our borderline, we can say, 50 to 60%. Are there any ECG changes in the lateral area, like ST depression in V4 to V6? I mean, do we really have to put a stent in the circumflex, or do you need the FFR or IVUS for teaching purposes? I think.
From this image, it looks like more than 60. I think at least 80 here.
Okay.
Why not IVUS? You have the catheter there and see the MLA there.
We can IVUS, but I think the time is a little bit limit here because we still have another RCA vessel to do, and this enormous RCA.
No, if we don't want to give the RFR, is definitely will be helpful. It will be quick.
Perfect.
Okay, go. Picture.
Yes. Fine.
Okay, looks good. All right, let's go.
What is the size of the stent? Talk.
3 by 32, Promus Premier.
Good, 12.
12.
Give 14.
14.
Okay, done.
Deflect.
Yeah, deflect.
Doc, where would that lesion will take you to appropriateness criteria?
STO. Say again, Tijan.
For that lesion, what's the appropriateness criteria there?
What is up?
It's okay, you can pull straight away.
But there's a calcium on there.
I would definitely QA that case if I am the cath lab director.
Sanjay is a cath lab director here. I think we do the right. Okay,
Yes.
they are one. Let's take a picture. I take a picture here.
Take picture.
Yeah.
Fine.
Okay. Do another view. Yeah, one more view.
Are caudal or yellow caudal?
We'll record it.
Are you
Yellow
going to
caudal.
do it in IVUS now, Tak? Because the proximal part looks not fully deployed.
Okay.
Yeah, we can do an IVUS here now. We can.
Looks good.
We can do an IVUS
Okay.
for QS.
Plus.
It's always a bad combination to have a left main calcium, circumflex lesion, and tortuous. You got to always have that danger of getting dissected the left main. We have to be always keep an eye on the ostium of the, ostium.
Correct. So the guy really need to be very careful when we get the catheter in and out, especially when you pull out the balloon, the guiding catheter. You don't want something happen.
Yes.
It's okay? Right. Let's
Still
go.
little outside.
It's okay, right?
Okay.
Okay, we're live?
Yeah.
Okay. Great. Yes, please.
Okay, this is a distal to distant small plaque, eccentric plaque. But the other side is looks normal. And here you can see the stent. Position is okay and no dissection.
1, 2.
Right.
It's
The
a 3
lumen
minute.
size is nearly 3, right? Yeah. Yeah, the symmetricity is okay. And here is the concentric plaque, and the lumen size might be nearly 3, right?
Still 3 over here.
Yeah. Okay. You can identify the calcium in 3 o'clock, but the stent expansion is okay, right? Yeah, also the calcium.
There's some calcium.
Yeah. So yeah, here it might some under expansion, I'm afraid, but now okay, right? So the branch comes in.
Mhm.
Yeah.
That's it.
Yeah. This is an yes.
Okay, done.
Approximation. Very yeah, wonderful.
So what do you think?
Yeah, only one lesion, I'm afraid, is under expansion. Just a little bit distal from the proximal edge, right? A little bit more. Right.
No, the edges looks
Yeah,
good,
yeah,
right?
edges looks
Edge
good.
looks good,
Yeah.
but
But
the stand expand well.
yeah, could you measure the proximal stand area, right? And then the most stenotic area. It's an 5.78, right? It's good. A little bit distal from here. Yeah, around here, right? Okay. Could you try
Measure
to
that.
measure? 4.22.
So acceptable, or should we post dilate a bit bigger?
A little, yeah. But yeah, you can identify the calcium more than 180 degrees. So,
Yes.
try to do the high pressure ballooning. Otherwise, yeah, we cannot get enough lumen area.
So
right?
we need a high pressure balloon.
Yeah.
Okay, give me a 3.0 high pressure balloon or 325. 325 is good.
325. 3.25 by short.
Yes, I think you definitely do need to post-dilate here. I mean, the MLA is suboptimal, and I think it will expand. I mean, I agree that there is calcification, but it's not completely 360 degrees. So I think you'll get good expansion, good results with a high-pressure balloon.
Yeah, 325.
They are bringing.
So we prepare the guiding catheter for next vessel.
Okay, air.
AR.
Air is here on.
Ready? Okay.
So, Tak, the under-expanded area is quite short. Are you going to use the short non-compliant balloon
Yes.
or a longer one?
I think short is good. Yeah. They getting there now. I just a 325 short balloon.
Launcher motor John.
A10, what's that?
Happy.
12.
Oh, we have 3.5.
3.5 a little bit big. No, we are 3.0?
3.0.
3.0 is okay. 3.0 high pressure.
Yeah.
Short one, 10 is good. Okay.
Okay, तो आलेंगे इसमें.
Sanjay, you have OPN balloons in your lab? Sanjay?
No, we don't.
You don't have. Suppose if this
Yes,
doesn't
right.
yield because of the calcium, then no.
No, we don't. We generally do rotablator then.
Well, this one I don't think we need rotor. It's
Yeah,
not a.
it is a very tortuous circ.
Yeah. It's it's a calcium, but not severely calcified. So this one can be easily done with a high pressure balloon. You guys see how Sanjay put the wire in the balloon? He using the scoop technique. So only the area is a proximal to mid area, I think short area. Should be here.
Yeah, there's a lot of wire biases there.
Yeah.
Proximally.
Go. Yeah. Then I'll pull back one more leg. Yeah. Go. High, high,
15,
high, high. 20.
20. Yeah.
Down. Okay, 20 down.
Yes.
Okay, good. Go. 20 again.
20.
Down. So I'd like to put my guy out. The balloon go forward a little bit, release the tension, and get a balloon to the guy and engage the guy back again. So this is I like this technique. I think I learned it from TJ, so we don't traumatize the left main.
Here, थोड़ी करो.
Take a picture. Take a picture.
Yes, take shoot. Wow, nice.
I think angiography looks okay, right?
Yeah.
Okay, so let me try to do RCA this moment, so we can
I was okay, fine.
take this one out. Get an AP view, please.
AP view.
Should I try using this one? This one won't go. Test for me. Maybe this one go.
Wire comes
No, test for me.
Oh,
All right, give me the wire.
yeah.
Let's see.
Wire clock.
If we're lucky, we can get the guy into the enormous right.
This is a
Backloading.
okay.
So, do you have much experience with other catheters, TAC, such as the Ikari catheter for doing
Cannot
both
see.
left and right?
I
on the
cannot see.
arteries? TAC,
Yes,
do you have much experience with other catheters, such as Ikari catheters? to enable-
Akari,
Yes.
not too much. We're using field. Akari left, Akari right, not too much. So in this case, you think it's good for Akari?
If you want to use a single catheter, then yes, I generally use Ikari left, and you can do multi-vessel PCI with a single catheter. I don't know how it would perform in this sort of case, though, with the anonymous right.
Oh, yes. Yeah. Almost there.
No, the wire's no good.
Little pull.
The wire's no good.
Oh.
Give me a new wire.
You want new?
New one, yeah. Give me a new wire.
Run through.
A new one.
Run
too.
through.
So what would be the right
Run-
catheter for this site actually? Probably Amplar's left one, AL1. May
Yeah, I
look
think-
into that way.
No backflow.
No
Little
backflow.
maneuver.
No backflow because they're against.
It's
the wall.
touching wall
Yeah,
actually.
touching the
so-
wall. Don't know.
Yeah. No,
Okay,
it
good.
has. Fine.
But this one can be AR, can be AL. But I using the EBUC. I had any luck going down or not?
Oh, you're already there.
Don't know.
It's already hooked. Yep.
Don't know.
Oh, there is bubble.
There's a bubble there in the
we
catheter.
have seen and we are removing.
Yeah, you've seen that.
Yeah, yeah.
You're better eye than me now. You okay? Little bubble.
Okay,
So let me see. Okay.
fine.
Okay. Good picture.
Yes.
Okay. Now,
Two strands.
2 stand or 1 stand. I probably 1 stand. Let's.
Okay.
You can IVUS it. Let's see.
Okay.
It's a very long lesion.
Yeah.
Very, very long.
I think we start from all the way down and then see. Probably 2 stand, right? You think I need a Garcia support extension?
No, I think you'll manage.
Teijin?
without.
No, I think this is sturdy enough I think there is not, I'm not seeing any visible calcium there. I think you should not find any problem there. I think you have to dilate that mid portion and then things should be all right. Yeah.
I hope so. I hope so.
Your wire is giving a lot of support. It has gone very deep
Yes.
down.
Now it's the start not going down smoothly.
Yeah.
No. Where is it? Where is it? This one is not moving at all. Do we see anything from here? I cannot see. Let me P-dilate it first, okay?
Yeah.
Give me a
But
2.5.
we can see this area?
Yeah, can we? But I cannot go. That's, no, cannot go.
Okay.
Can I have 2.5 Chorney balloon?
2.5, 20 or 18, 15 जो भी है. That bring
Yeah,
it.
you flush the catheter well. I think this catheter need to push in, right? So it's not pushed back in. Oh, okay. Yeah.
Is this a case for a spot stenting or a normal to normal covering? It is look like a whole length of the RC is diseased.
Yeah. I think full length disease. I think maybe 2 stent.
Yeah. That will be ideal.
Okay, should be, let's go. Start from here.
Okay.
Go. Go to 8.
8.
This is a non-compliant balloon, right?
Yes, emerge.
MH. Yes. Go. Compliant. 8. 12. Okay, looks open up here. One more here. Okay, good. Get IVUS catheter back.
So it looks like it may take two 48 millimeter stents.
I think so, but I don't know if 40 can go down or not. Okay. Let me see IVUS. How long is the lesion? So if we do an OCT, I still worry about the contrast. We in and out so many times. Triple vessel.
Yeah, if you
It's
worry
not a
about
good
the
idea, no?
total amount of contrast, we can use the low molecular dextran, right? Dextran lactate. The
If you do
image,
OCT, you need not go too many times in and out.
yeah, but the dextran is okay. Yeah, the image quality is a little bit poor compared with the contrast, but the clinically it is acceptable. So if you worry about the contrast volume in case with early stage of kidney disease, we always use dextran L, dextran lactate, 10% dextran. Yeah, it's good.
Still cannot hit the band.
Yes, nicely.
The guiding is still unstable, but still because of the strength of the
Okay,
wire.
let's. We see alive.
We are not able to see the IVUS. Yeah, now
Recording?
we can
Yes.
see.
We cannot identify
Can you see it?
Yeah,
almost normal here, right? Yeah.
Right here is normal, good.
yeah, some
Yeah,
plaque is there.
some very
Some plaque.
fibrous, yeah, but it's
So
okay.
right
Yeah,
here is the one I need to do from here.
right? Yeah,
Okay, so
it
this
start,
area,
right. And still plaque volume is not so big, right?
moderate plaque.
Yeah,
but I should cover that if my
Right.
stent can go down.
yeah. Here
Here,
also
I
the
ballooned that already,
looks
so-
normal, right? Yeah, but
Here's a plaque,
yeah.
major plaque. Right here, the
Here,
lesion.
here
coming
it
up.
might be the region, right?
So this is how big is the vessel? 3-0? 1, 2, 3.
Yeah, 3 or 1 2 3 1 2 3 3 0. Yeah, here is a negative remodeling, right? Yeah, and here becomes the big plaque, eccentric plaque comes in, and calcium here.
38 stent.
Yeah, some calcium.
38. Yeah.
Right. Where is one, two, three, nearly 4, right? Yeah, yeah. Proximal should be a 4, right? Here is a very
there's a
circular
calcium.
circular calcium or
This
yeah,
is calcium.
right.
Just hold on. The proximal part, a lot of calcium.
right.
Right here.
Yeah.
So
and
we need to do something.
yeah,
Okay?
very circular calcium, right?
Do you use a cutting balloon in
Right.
that area?
I think good idea.
Right.
Yeah, cutting balloon.
Yeah.
Yeah, 3-0 cutting a short one in that
Yeah.
area. You don't have it? Yeah. Okay. Then we had a high pressure balloon.
Still
Sure,
very
you don't
concentrated calcium. Part
You have
of
angiosculpt there?
Angiosculpt.
yeah,
Yeah.
right, right. Here also the
Still a lot of
nearly
calcium.
circular calcium, right?
Angiosculpt also will be very good.
Yeah.
If there is a scoring balloon, then
Yeah.
you can try that. That will be more
So
trackable
about
than that
4 vessel.
Yeah,
balloon.
I agree, right?
Okay,
Yeah.
cutting. 3-0. Okay, good.
Here is the nearly the orifice. Yeah.
Yes, this is okay. So in this area will be okay.
Yeah.
Okay.
Orifice is okay,
this
right?
way,
Okay.
Good. Yeah, we can start. Right? Start recording.
Yep.
Start recording, right?
In the UK, we use a lot of lithotripsy. This would be absolutely perfect for that segment. We've had great success with lithotripsy balloons in this sort of very focal 360-degree concentric calcification where rotablation won't touch the edges. I think lithotripsy would be perfect.
Mamas, you can you describe
Yeah,
how
cutting
much
balloon.
this whole process of the lithotripsy takes? How much time it will take to melt away this calcium, which is
So each balloon, you can apply 40 pulses in each balloon, and often
So-
you see
so-
in about the first 10 pulses that the lesion will expand, and so it's not that long.
So let me ask a panel. When you see this iris, how many people change their mind, do the cutting balloon, do the rotor blader before we put in stent? Or anyone just say, go ahead, high pressure balloon and stent? What is the consensus there?
I think diameter was too big still for rotablation. Even 2 bar will slip through that. So you have no option but probably take
Right here,
high
eh?
pressure non-compliant balloon,
Yeah.
and if it gives
Test
in,
on
then
this.
stent in.
Make sure I'm in the right area.
Question for you, Mamas, is
Yeah, let me go
when
down
you do
here.
these lithotripsy,
Okay, let's
you
go
guys
here.
check the troponin at all post-procedure and any debris embolus with it?
Slowly up,
No,
slowly
we
down.
don't. So we don't check troponin unless
So
there's
6
some
is
sort of
normal, but this is a
complication. I think in this sort of
3-5
case,
vessel
I would
almost.
very
So we
much
go to 10.
use
Okay.
a cutting balloon or something.
slowly up.
Because if you deploy the stent, then you're going to have a problem expanding it. And if you start trying to lithotripsy a deployed stent, there's always a worry about compromise of the coating and the drug and the polymer and so forth. So I always advocate treating the vessel
10.
appropriately beforehand and then deploying the stent.
one more issue with this kind of anomalous
ST.
RCA is it is quite dangerous. You may invite more complications by attempting rota this sort of anatomy. So you may
one more
harm the
here.
wire.
Okay.
You can dissect. So I think I will keep away myself from like abnormal anatomy for rota.
Good. All right. Down. Open. Okay, go. So 10 looks open up. There's a bubble here. Slowly go to 10.
What is this balloon, Sanjay?
3x10 flexotome.
Down, down.
Flexotome.
Heart rate, sleep is slow. That's okay. Test from the face. It's okay?
Yes, this is okay.
Do cut one more cut.
Yeah, I'm going up.
Yeah, going up. The heart rate you can see drop a little bit once they cut. I think this artery. Good. Good. Okay, good. Test that. Right.
Yeah, good dissection.
Good dissection, huh? Something called good dissection. Something called bad dissection. So we agree we put a stand now.
Yeah,
A 3 what? 3035.
35.
35.
35.
We are 32 or 38?
38.
38?
Yeah.
3.538.
So we go down.
So if the stent doesn't track, what's the trick you are planning? What's the plan B?
I think Godzilla is a one check. Second thing is a short stand. Couple short stand on that. I think we'll be okay.
Like a stent like Onyx, they are very, very trackable.
Which one?
Onyx,
Onyx.
from Medtronics.
Yes.
Yeah, they are very, very trackable. Even tortuous, calcified. That's one of my choice. It could be such situations.
What's then this one?
Promus Premier 3.5 at 38.
Yeah, it went on just like that.
I think it's okay, right? Yeah. It's okay?
Yes.
Okay, go.
Operator
So we need
scale.
2 stand, huh? Another one, go. So, yeah, 10, 12.
You make it look so easy, Tak.
Done. I don't know. I think this is Sanjay. Come on. Just Sanjay do all the work. Let me do a part here. Okay, I pull back a little bit. Okay, let's do it here. Go. Go higher.
So this is very important to
16.
flare up that proximal edge.
Yeah.
Otherwise, the next stent which is coming
Yeah.
in will be make it very difficult for the second stent.
Now the
coming
next
in.
one is
So we have to flare it up with a high pressure.
Take size.
That will make prepare the proximal edge of the stent.
So
Okay to receive the
take a
second.
picture here.
Okay.
Ready? So next one will be 32, right? What do you think? This is 38,
Yes.
right? So 32? 3532? Don't look at the dissection, it's bad.
By IVUS it was 4.0, isn't it?
It's a 4-0 or 3?
4-0.
4-0. So let's
Proximal
get a
was 4-0.
It's 4-0. I forget the IVUS now. So let's 4-0-32. Okay.
Yeah, right.
Looks good.
No, I just didn't want you to post dilate.
Is the IVUS lie to us?
No, I just didn't want you to post dilate with 4 afterwards. That's why.
Okay.
What's your antiplatelet regime here, Tak? What's it going to treat this chap for and for how long?
4-0-32.
Tak, how long are you going to treat this guy with antiplatelets and which type of regime?
I'm sorry?
What antiplatelets regime
DAPT.
will you use?
Huh? DAPT. Oh, DAPT. How long?
Yeah, how long and which one?
Well, I mean, probably it's a 6 months to 6 months if a patient is stable angina, even though multiple stent. So if the patient is acute case, is probably 1 year. This is the guideline, right? What do you think? Is a British the same system? Or the shorter one?
How many people will use only 6 month DAPT in the audience here?
Okay, that's a picture.
How many will use for 1 year?
What do you think?
I think most of them are now using 1 year at least. Even in my practice, what I do is first 6 months I use a ticagrelor along with aspirin for the first 6 months.
Distal, no.
And
Distal
then
one
I
when you go in.
do switch over to the clopidogrel with aspirin.
Pull back. Okay. Should be okay, no? Test one.
I can't quote any guideline for that, but
I think we should.
that's
Okay, no?
what's
Go.
economically viable
Yeah,
for me.
otherwise. Sure.
I mean, so for electives, we generally use 6 months in the UK, but then we also use the DAPT score. And in patients where we feel that the DAPT score suggests that there may be a benefit, then you can prolong your DAPT for longer than a year even.
Yes.
Okay, go. Overlap, yeah. I just try to go to overlap a little bit.
12,
14.
14.
Done. Picture and iris, okay? The air, make sure no air. Okay, let's picture and then iris. Ready? Okay, give some nitro and then we iris. Yeah. What do you guys think?
Yeah, it looks great actually. There are some tissue prolapse happening in the middle portion, but some bumpy thing is there.
Okay, good.
But otherwise it looks great.
Yeah, let's see the iris catheter.
What stents were there?
Promise stand.
Thomas Premier.
The case ready next door and then we okay.
Promise Premier, they got
Is
the
ready?
proximal links are made more sturdy because we had a lot of longitudinal compression with the previous versions of the Promise. So now Promise Premier is actually fortified in the proximal region, so we don't see much of the longitudinal compressions. But still it can happen. If the guide hits that edge, then still it can happen.
Yeah. It's okay. Okay, right? Let's go. Let's read live. This king.
Yeah, very good.
Should be here. Recording? Okay.
It's a distal to the stent. Yes.
Somebody is watching the ACT. How much is the ACT? Anybody?
ACT generally we do at the end of the procedure.
They give a 10,000 happen, right?
Most of the time it is above 300.
We had a long procedure.
Yeah.
Some plaque here.
Yeah. So still distal to the stent, and
So we covered the distal lesion well.
Yeah,
I
here
don't
you
see
can-
any plaque in
right,
distal.
right.
No dissection here, right?
Yeah.
I don't see dissection. The stent well approached at the end.
Yes. Stent area might be around 3, right? Yeah.
The distal stent, yes.
Yes. Yeah, our position is good. Yeah. Yeah, here some tissue prolapse in 9 o'clock, but here is a little bit asymmetric because of the eccentric plug, right? But area should be okay, right? Here is an well expand 3.5 around.
It's still
yes,
good here, the stent.
Yeah.
Looks like
Here start
This
the
is the
calcium.
area, the calcium.
Yeah, right. But here the opening is okay,
yeah,
right?
the calcium looks okay.
Yeah, right.
We still have 3-5 lumen here.
Yeah. Will expand, right? Yeah.
Well expanded stent.
Here might be the overlap.
This
Possibly.
overlapping stent here. Yeah. We are overlapping.
yeah.
There's a actually a 4-0 stent
Yeah,
here now.
right.
The proximal stent.
Is
looks
also
good.
the 4O, right? By IVUS. Yes.
Some tissue prolapse, right?
Yes. This might be some nod, right? But it's okay. Right. Yeah, the proximal also the very wonderful, right? Yeah, right.
Maybe just too long. this error. Okay.
So
that's a
end of
king
that you
cover.
get tired. That's
Yeah,
the problem.
the iris get tired. Okay, so let's ask the expert opinion.
Yeah. Generally speaking, it's a very wonderful result. I cannot identify any under expansion, even in a region of calcium. The result is wonderful, more than 3.5, and proximal side looks nearly 4 by IVUS. It's okay. So
I think it's okay. I think I can stop here. What do you think, guys?
Yeah, fantastic.
Okay, great. All right.
right.
Thank you very much.
Congratulations. Yeah.
Yeah. Take one more. Okay. Yeah. Okay, good. The CPU. Looks good. Okay.
Hello, can you guys hear me? Hello?
Yes, we can hear it.